Hello students, again we will discuss a very common entity which we see in the oral cavity. Just see this, what this condition is. Look at this oral cavity, look at the lateral margin of the tongue. There is ulcer, some area of proliferation, here it is everted edge, like this, everted edge. And if you definitely when you palpate, there may be induration, you have to look for the fixity, you have to look for the tongue movement, so that ankyloglosia, you have to look for the neck lymph nodes, level 1A, 1B, 2, 3, 4, 5, and both sides you have to examine, you have to palpate oral cavity, you have to look for the mandibular thickening by bilateral examination, and posterior third of the tongue you have to extract, floor of the mouth you have to palpate, entire oral cavity you have to examine properly. So what is this carcinoma tongue? So which is the commonest site and what are the features? Remember, already told, lateral margin is this is the commonest site of tongue carcinoma, 50%. Next is posterior third behind. SCC is the commonest type histologically. Of course, the adenocarcinoma, melanoma, rare tumors, malignancy can occur, but this is the commonest type. Remember. So how it presents? Painless ulcer initially, but eventually, once it infiltrates, it can become painful. Otherwise, begin with always painless. Progressive, excessive salivation later becomes painful. Hard induration is the hard, typical hardness of malignancy. The very, very typical of squamous cell carcinoma, remember, or carcinoma as such. To look for fixity to the floor of the mouth, bone, mandibular thickening, ankyloglosia, tongue cannot put forward, floor of the mouth, extent, nodal spread, both sides, and all levels. Of course, systemic exam, mainly lungs you have to look for. Lung mainly because they aspirate, they have bronchopneumonia. Spread to the lung, systemic spread is not common in oral malignancy, that is in squamous cell carcinoma, unless patient is immunosuppressed. Immunosuppressed can occur, otherwise it is usually loco-regional malignant disease, but very, very aggressive. Remember, carcinoma tongue is very aggressive compared to the lip, buccal mucosa. So how to manage? Wedge biopsy from the edge, minimum 2 or 3 biopsy to take. Ultrasound neck for the FNEC and for the lymph nodes and FNEC of neck nodes. CCT head, neck and chest you have to remember. That's very, very important. Treatment is wide. Currently many people do PET CT, but this is sufficient usually in early stage. Treatment is wide local excision. Then reconstruction, either skin grafting, suturing or some flap, nasolabial flap, whatever it is, whether on the whether on the idea of the reconstructive surgeon. And neck node dissection, usually bilateral if it is so, you have to do bilateral neck node dissection. Usually MRND, if it is a very aggressive malignancy, if you think, then you do a radical neck dissection. This is the treatment strategy. You have to remember always, very common entity will be kept as a short case in the exam, short note in the theory, oxy they will keep. So day to day in surgical OP or ENT OP or patient auxiliary or oral cavity, oral malignancy, oral OPs, you will get such patient. So any tongue ulcer, think of carcinoma, rule out carcinoma based on these clinical features. That is the point you have to remember always. So go through my clinical methods, how to examine oral cavity, my manual to detail about carcinoma tongue management, concept, everything, investigation, everything, operative surgery for surgeries and reconstruction. My DigiNow gives a proper lectures about all these things, covering everything, UG syllabus and basic PG syllabus. So I hope you understood, students, carcinoma tongue basic very clearly. Thank you very much.